or much more retardation doesn't tell us any of that, and it also should never direct resuscitative or direct treatment. So it's just a snapshot in time, tells us what the baby's doing at that 1 minute and the 5 minutes. So it does not guide therapy, your clinical reasoning does, and it does not predict outcome for the child. So those are important things to remember about the APGAR score. You want to make sure you got that question right. You can miss some other ones, but we'll get the APGAR one right. Okay, so now we're examining these precious little babies in the newborn nursery, and we're assessing a Moro reflex on a large for gestational age infant. The right arm remains extended and is medially rotated. So what's wrong with this kiddo? So you can do it, right? Medially rotated, kind of like somebody wants a tip of some kind. Clumpy is the claw, so this is Erb's. This is Erb's palsy. And they may go all step one on you and ask you about the nerve roots. Probably not, though. I think if you can pick it out in a clinical vignette, you'll be okay there. The key for treatment is there is neurosurgery that's available to fix it. If it doesn't go away on its own by 3 to 6 months, you refer for surgery. They can surgically correct these now. So we've got another large for gestational age baby, and we're palpating the clavicles, and we feel crepitus and discontinuity. So what is that a sign of? Clavicle fracture, very good. And more importantly, they're going to ask you what we need to do for this baby. Very good. So very different from adult medicine. Usually the newborn's bones are much more apt to remodeling, so they're going to form a callus, no treatments needed. I've read some places that you can use a figure of 8 splint like you do in adults, but not necessary. Okay, so what about my first little kiddo with the funny shaped head? And if you palpated the baby, you might feel edema that crosses suture lines. Caput, very good. So edema, it's pitting. You know, like the people who have pitting edema on the legs? These babies, you can leave a thumbprint in their head. So that's edema, it's spongy, and it does cross the suture lines. That's caput. What about my other little friend? Well, maybe the picture's not the greatest, but if the description tells you it's fluctuant when you palpate it, and the fluctuance doesn't cross suture lines. Yeah, so this kiddo just happens to have them bilaterally. I couldn't find a picture where it was just one. But you see down the middle of the suture, it's not crossing the suture lines. He's got them on both sides. So just remember that. Whether or not the swelling crosses the suture lines is a big distinguishing factor between caput and cephaly.
My specialty is radiation oncology, and here at MD Anderson, I'm further subspecialized in the treatment of gastrointestinal cancers. I became a radiation oncologist because I
hematoma. All right, cute baby rashes. So this first one, it might be described as a blue slate gray macule on the back or thigh. Good. And what are they made of? If you biopsied that little lesion, melanocytes. Very good. 2 extra points for you. Just kidding, I can't do that. So they're arrested melanocytes. That's what the Mongolian spots are made up of. Okay. So our second little baby has pale pink vascular macules on the nuchal area or the face. The facial ones tend to disappear, but the ones on the neck can persist into adolescence, and these get like more red if the kid gets angry or does sports. Salmon patch. This is the nevus simplex. So hemangiomas are more sharply demarcated and red. Better and don't tend to be on the face and nuchal area. So the location should be a helpful factor in determining nevus simplex. So face, nuchal area, the facial ones will regress, the nuchal ones will stick around. Okay, so our little baby with the hat over his eyes, you can't really see them very well in this picture, but they'd be described as firm white papules. You'll see them on day of life number 1, and they're filled with keratin milia. Good. So what do you not want to confuse this with? Other little bumpy things on a baby's face. Neonatal acne. So what's the difference? Size, not so much. Timing. You won't see neonatal acne on day of life 1. It typically doesn't show up until week of life, maybe 1 or 2. So we'll see that in a little bit. Timing. Size, not so much. Timing. You won't see neonatal acne on day of life 1. It typically doesn't show up until week of life, maybe 1 or 2. So we'll see that in timing. You won't see neonatal acne on day of life 1. It typically doesn't show up until week of life, maybe 1 or 2. So we'll see that in a little bit. So this third baby, or the fourth baby, the lesions, I don't know if you can see them, they might be described as firm yellow-white pustules and papules. On an erythematous base. You might see them on day of life number 2. Very good. Erythema toxicum. And what are they filled with if you took a biopsy? Eosinophils. Very good. Very good. Okay, so in baby number 5, here's your bright red, sharply demarcated, raised lesion. Usually occurs in the first couple months. Yeah, here's your hemangioma. So they're typically smaller and they're raised, so they're palpable. The nevus simplex or the salmon patch, typically you can't run your fingers across it. And here your baby service, they're typically smaller, marcated, raised lesion, usually occurs in the first couple months. Okay, so in baby number 5, here's your bright red, sharply demarcated, raised lesion, usually occurs in the first couple months. Yeah, here's your hemangioma. So they're typically smaller and they're raised, so they're palpable. The nevus simplex or the salmon patch, typically you can't run your fingers across it. And here, baby number 6, this might happen on week of life 1 or 2. Erythematous papules, these are the neonatal acne. So I think time is the biggest clue there in determining between milia and neonatal acne. And neonatal acne, just like in adolescence, or if you're unfortunate like me in your 20s, it's due to what? What causes acne in these babies? Yeah, hormones. Same reason. Same reason it occurs in adolescence. So it's just the maternal androgens that are high circulating levels in the baby. All right. So what about this kiddo? What's on his face? Nevus sebaceous. Seborrhea is the next one. So nevus sebaceous, you might see it described as an area of alopecia. So you see there's not hair growing in that lesion. And the skin is orange colored and it's nodular if you run your fingers across it. And what do we do with these lesions? Are they just going to peace out on their own like some of our other cutaneous? Very good. So we remove these before adolescence because they do have a risk of malignant degeneration. So nevus sebaceous, this nodular orange lesion needs to be removed. Here's our seborrheic dermatitis. A common name for this, it's on the baby's head, like a little cap, cradle cap. And what do we do for this? Antifungal or a mild shampoo. Usually it's pretty easy to get rid of. You treat it similarly in adults. It's a bigger a deal in adults because it usually only happens in adults with HIV or AIDS, but in babies, it just happens in babies. So just gently cleanse it. Sometimes they'll tell you to put the shampoo on a toothbrush, a soft toothbrush, and scrub the lesions. Okay. So any questions about skin findings you might see on a neonate? They might show you a picture. More often, though, they're going to describe it. So when you're studying, keep in mind those keywords that kind of distinguish each of the lesions from each other. Any questions? Fair enough. All right, so on the neonatal screen, it varies slightly between states, but there are 2 disorders that are always screened for, and it's important to catch them early because it can lead to disastrous consequences if the baby's allowed to breastfeed. Galactosemia and PKU. Very good. So PKU, you remember it's important to catch them early because it can lead to disastrous consequences if the baby's allowed to breastfeed. From each other. When you're studying, keep in mind those keywords that kind of distinguish each of the lesions from each other. Any questions? Fair enough. All right, so on the neonatal screen, it varies slightly between states, but there are 2 disorders that are always screened for, and it's important to catch them early because it can lead to disastrous consequences if the baby's allowed to breastfeed. Galactosemia and PKU. Very good. So PKU, you remember this from biochemistry or from step 1, it's a deficiency in phenylalanine hydroxylase, and the symptoms, you don't see them right away. In galactosemia, you see the symptoms right from birth because galactose can cross the placenta and starts to affect the baby when it's still in utero. PKU, we don't see the symptoms until a couple months later, and you start seeing delay in development, signs of mental retardation, and then there are those classic signs with the white hair, the kind of musty, mousy odor that they often describe in questions. In galactosemia, it's a problem with this G1P uridyl transferase that you probably remember from biochemistry, and it causes this precursor, G1P, to accumulate and cause damage to a lot of the different organs in the body. And these cataracts, jaundice, seizures, all of these findings are found right from birth because galactose can cross the placenta. So these are a big deal because there's obviously lactose in breast milk and there's also phenylalanine. Okay. So a yellow baby. Lots of questions on your test, at least 2 probably, about neonatal jaundice, just because there are so many different reasons. And treatment is important. So if we have a yellow baby that is 3 days old, the Billy's 10, and the direct fraction, or the direct bilirubin, is only 0.5, and the baby's, because there are so many different reasons, and treatment is important. So if we have a yellow baby that is 3 days old, the Billy's 10, and the direct fraction, or the direct bilirubin, is only 0.5, and the baby's pretty much okay, eating and pooping well, what would we suspect to be the mechanism or the problem? Yeah, so this is just physiologic jaundice. It's physiologic if it's gone by day 5, and it's just because the neonate's liver isn't mature enough to fully conjugate all the bilirubin that it's taken in. So physiologic jaundice before day of life 5, and the bilirubin usually isn't higher than 12 or 15. So what about another yellow baby, 7 days old, the bilirubin is 12, direct bilirubin is 0.5, but the mucous membranes are dry and the baby's not gaining weight. Old, the bilirubin is 12, direct bilirubin is 0.5, but the mucous membranes are dry and the baby's not gaining weight. What about another yellow baby, than 12 or 15? So what about another yellow baby, 7 days old, the bilirubin is 12. direct bilirubin is 0.5, but the mucous membranes are dry and the baby's not gaining weight. Breastfeeding? Yes. So breastfeeding is kind of a misnomer, which is why it's hard sometimes to remember. They really should call it lack of breastfeeding jaundice, right? Because the problem is the baby's not getting enough breast milk. Baby's either not latching on well or not sucking well, or the mom's not feeding frequently enough or for long enough, and you'll see all of those clues in the question stem. So you can pick this out in a clinical vignette because the baby will often have signs of dehydration as well as the jaundice. So what about our third baby who's 14 days old? Billy is 12, direct is 0.5, and the baby had regained its bilirubin as well as the jaundice. So what about our third baby who's 14 days old? Billy is 12, direct is 0.5, and the baby had regained its birth weight and is otherwise healthy. Breast milk jaundice, very good. So this baby, in contrast to baby number 2, doesn't have those signs of dehydration. They're getting adequate calories from the breast milk. The problem here is that there's an enzyme in breast milk called glucuronidase, and it deconjugates the bilirubin in the infant's GI tract and causes the indirect bilirubin fraction to increase. So our last baby is 1 day old. Bilirubin is 14, direct is 0.5. Are we worried about this kiddo? So our last baby is 1 day old. Bilirubin is 14, direct is 0.5. Are we worried about this kiddo? Yeah, so high bilirubin in the first 24 hours of life is always a problem. That's always a cause for concern. It's always pathologic, so to speak. So it's always pathologic if it occurs on day of life 1, if it's over 12 at any time, or the direct bilirubin is over 2. And also a fast rate of rise is cause for concern. So what do we want to do as our next best test? Shelfs love these questions, right? What is the next best test in the workup of your patient? Very good. Very good. You'll want to do a Coombs test. Why? Yeah, because you want to see, well, we already have a clue that it's hemolytic anemia, or there's hemolysis because the indirect bilirubin is up. And we can tell by Coombs whether, well, yeah, we can tell if it's hemolyzing. We can tell if there are antibodies on the baby's red blood cells causing the problem. So if Coombs is positive, it means we've got an incompatibility issue, and it's negative, there's something else, either a twin-twin transfusion, maternal fetal transfusion, or a variety of other problems, including problems with the fetal red blood cell like spherocytosis, or other problems with the membrane. Okay, so still on yellow babies. This one is 7 days old. The urine is dark. The stool is pale. Bilirubin is 12, but direct bilirubin is 8, in contrast to our other patients. And here the LFT problems, including problems with the fetal red blood cell like spherocytosis, or other problems with the membrane. Okay, so still on yellow babies. This one is 7 days old. The urine is dark. The stool is pale. Bilirubin is 12, but direct bilirubin is 8, in contrast to our other patients. This one is 7 days old. The urine is dark. The stool is pale. Bilirubin is 12, but direct bilirubin is 8, in contrast to our other patients. And here the LFTs are also elevated, which gives us a clue. What's up with this baby? Yeah, so this is classic biliary atresia. The LFTs are elevated, it tells us something in that neck of the woods is not going well. And it's a direct bilirubinemia, which always causes us concern. So in biliary atresia, it's a congenital problem. The bile ducts are atretic, so the bile can't drain. It backs up, goes into the blood, and causes the jaundice. And this is a surgical urgency, if not emergency, because it will cause liver failure if not surgically corrected. So some other causes of direct hyperbilirubinemia, you see a baby, maybe their LFTs aren't high, but it's a baby that's got high direct bilirubin. What's the first thing you want to make sure you rule out? This is a surgical urgency, if not emergency, because it will cause liver failure if not surgically corrected. So some other causes of direct hyperbilirubinemia, you see a baby, maybe their LFTs aren't high, but it's a baby that's got high direct bilirubin. What's the first thing you want to make sure you rule out? Obstruction would probably give us some kind of liver signs, at least in terms of LFTs, especially with little babies that can't tell us how they're feeling. I'm being too esoteric. So you always want to rule out sepsis. Sepsis is a potential cause of a direct hyperbilirubinemia, and that's always one you want to rule out first by doing a pan culture, just like you do with the baby who has a fever. Some other random causes, galactosemia, hypothyroidism can present with direct hyperbilirubinemia, choledochocyst, not a atresia, but just a cyst on the duct, and then cystic fibrosis also. So this is back to step one again, random inherited causes of an indirect hyperbilirubinemia, named for dead guys. Gilbert's and Kriegler-Najjar. Which one is worse? Kriegler-Najjar, very good. So in Gilbert's syndrome, it's just a decrease in the glucuronidyltransferase. In Kriegler-Najjar, at least in type 1, it's a total deficiency, and that's a problem. So two more dead guys, random causes of direct hyperbilirubinemia. Roters and Dubin-Johnson's, very good. So these are problems not with glucuronidation, but with two more dead guys, random causes of direct hyperbilirubinemia. Roters and Dubin-Johnson's, very good. So these are problems not with glucuronidation, but with secretion or absorption. So Dubin-Johnson's and Roters, the only difference that I ever remembered is if you happen to look at the liver, it's black in Dubin-Johnson, and in Rotor, it's not black. How that's important clinically, I'm not sure. Okay, so why do we care about this at all? High bilirubin in our babies, why do we care? Very good. So we care, especially in the indirect bilirubin, because it can cross the blood-brain barrier, and it causes kernicterus because it deposits in certain places in the brain. And the two places that you probably should be aware of for your exam are the basal ganglia and the cranial nerve nucleus. guy. Those are the places that indirect bilirubin will preferentially deposit. And we particularly worry, the cutoff for extreme worry, I guess, would be if bilirubin is over 20. And what do? How do we fix this hyperbilirubinemia? So if it's really severe, especially if it's over 20, we're definitely going to do an exchange transfusion. What if it's not quite that severe? What would we try first? The spa, the tanning salon, for a little phototherapy. And how does that help? Good. So they're saying here, Harlingen, that it isomerizes the indirect bilirubin. And that's important to remember because there will always be an answer choice that says conjugates it or turns it into direct bilirubin, and that's not the case. It isomerizes it, which somehow chemically makes it more soluble and able to be excreted, but it does not turn it into direct. Okay, very good. Questions about jaundice? It's a fairly big topic in the newborn section. All right, so let's talk about some respiratory disorders in the newborn. So we've got a baby. He's in respiratory distress. His abdomen is scaphoid, and he has this chest x-ray. What do you notice on this chest x-ray?
There's gut in the chest.
Yes, so all of that bowel should not be where the lungs are, right? That is abnormal. So that's our biggest concern. Well, what's our biggest concern about that? Guts in the thorax, who cares? Can't breathe because our lungs can't develop, right? So this is a diaphragmatic hernia. That's what allowed the bowel to come into the chest. And we're concerned about pulmonary hypoplasia because this was going on during development as well. So the lungs aren't able to develop normally with all that gut getting in the way. So we're worried about pulmonary hypoplasia. That's what's going to kill this baby if we don't treat it. And how do we treat it? Surgery. Do we do surgery? So catch the baby, throw him in the OR? I say it that way because it's no, right? When's the best time to do surgery? A couple days later. You want to give the lungs some time to mature. 3 or 4 days is the optimum time between birth to surgery. There will be an answer choice that says, deliver the baby in a delivery room adjacent to an OR or something like that. They like to ask the question, a mother knows she has a baby with a diaphragmatic hernia. What's the best advice to give this mother prior to delivery? A, have her deliver in a delivery room adjacent to an OR. B, I don't know, blah, 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 blah. Usually the right answer is have her deliver at a facility with ECMO capability, extracorporeal membrane oxygenation. That's been the right answer, at least in the questions that I've seen. Okay, so another baby with respiratory distress has excess drooling baby who can't breathe. What does that make us think of? Esophageal atresia, or TE fistula, yep. So the best diagnostic test for this? Yeah, so very low tech, right? Shove something down its nose and take a picture. And if it coils in the thorax, you know it can't go all the way down to the stomach. What else should we look for? Pediatrics loves this business. So we found TE fistula. We're going to look for other things in the Bacterial Association. So particularly the right answer might be renal sonogram. It might be skeletal survey to look for radial anomalies. So keep that in your mind, that association, other anomalies that present with TE fistula. So what about our third baby who makes it, it's about a week old and becomes cyanotic when feeding, but when she cries, she pinks up. What's that? Choanal atresia. So that's choanal atresia, and here's the other pediatric style question. What else do we look for? There's an association that includes choanal atresia. Charge. Good. So coloboma, heart defects, growth retardation, GU anomalies. Ear anomalies, and deafness. I'll go with charge. Good. Okay, so these are newborns. The first is a 32-week-old preemie born with dyspnea, respiratory rate. That's 80, nasal flaring, and this chest x-ray, they might either give it to you to look at, or they might tell you that it has ground glass opacities with air bronchograms and atelectasis. So it's that. That's respiratory distress syndrome. It's RDS. So how do we diagnose this prenatally? Ideally before the mom delivers. Yeah, the LS ratio. I can never pronounce the word that starts with L. Lecithin, sphingomyelin ratio. If it's less than 2, there's a bigger chance of having RDS. So ideally, we'd like to test the amniotic fluid for that before the mom delivers. If we catch it early, we can give antenatal betamethasone to help stimulate lung maturation. So what's the problem in RDS, the pathophysiology? Yeah, so there's not enough surfactant. Without surfactant, we can't keep the alveoli open. That's why we see the atelectasis and ground glass stuff on the chest x-ray. And that's why the baby can't breathe. So how do we treat it? Very good. So one of the wrong answers is typically going to be theophylline. When do we use theophylline in the NICU? Yeah, so if it's central apnea, if it's problems with respiratory drive. In babies with RDS, they don't have problems breathing. They have problems oxygenating. So giving theophylline is not going to help. That's a common wrong answer that they give. So our second kiddo is a 38-week-old, large for gestational age infant, born via C-section to a diabetic mom. And the kid was dyspneic and grunting at birth. So what's that? TTN. And what are large for gestational age infant? Oxygenating. In babies with RDS, they don't have problems breathing. They have problems oxygenating. So giving theophylline is not going to help. That's a common wrong answer that they give. So our second kiddo is a 38-week-old, large for gestational age infant. born via C-section to a diabetic mom. And the kid was dyspneic and grunting at birth. So what's that? TTN. And what are, I've given you the chest x-ray. What are kind of the buzzwords that go with that? Perihilar streaking because of fluid, right? Retained fluid in the fissures, the perihilar streaking, and sometimes air trapping. You see that that chest x-ray looks more black, looks like it's got air trapped in there. So that's the characteristic chest x-ray for TTN. And what's the problem in TTN? Yeah, retained fluid. And they say that C-section is a risk factor for this because the baby can't go through the birth canal and have the physical expulsion of that lung fluid. I think I had an attending say that that wasn't true, but I've read books where it says it is true. So it's kind of one of those times where what you do on the shelf is not what you do in life, and that sucks, but it's kind of how it is sometimes. So prognosis for these kiddos, super good. It's one of the best lung diseases to have if you're a newborn. So typically you just supplement them with O2 for a couple days and they're fine. So our last baby, 41-week AGA infant, born after rupture of membrane, yielded greenish-brown fluid. Are we worried about this kiddo? Yeah, we're very worried about meconian aspiration syndrome. And you can see this kind of looks like pneumonia. They might describe the chest x-ray with it says it is true. So it's kind of one of those times where what you do on the shelf is not what you do in life, and that sucks, but it's kind of how it is sometimes. So prognosis for these kiddos, super good. It's one of the best lung diseases to have if you're a newborn. So typically you just supplement them with O2 for a couple days and they're fine. So our last baby, 41-week AGA infant, born after rupture of membrane, yielded greenish-brown fluid. Are we worried about this kiddo? Yeah, we're very worried about meconian aspiration syndrome. And you can see this kind of looks like pneumonia. They might describe the chest x-ray with patchy infiltrates, because it is. It's a type of aspiration pneumonia. So meconian aspiration syndrome. Next best step. If you're the pediatrician in the delivery room, what do you do when you catch the baby? Yes, before stimulation. Because they might have your answer choices. So this baby's born. We knew that the meconium had stained because it was greenish brown fluid. What do you do after birth? One of the wrong answers would be, stimulation, drying, all the normal stuff that you usually do when a baby's born. So you want to intubate and suction before any of that because you don't want the child to further aspirate that material into their lungs. So complications of this. Yeah. So pneumonia, pneumonitis, and because there are problems with all of that meconium in the lungs, it causes pulmonary artery hypertension because blood can't effectively flow through. With all of that meconium in the lungs, it causes pulmonary artery hypertension because blood can't effectively flow through. Okay. So GI problems in our little babies. What's this? Okay, very good. And it's lateral to the midline, doesn't have a sac. That's how you tell it from omphalocele, right? So is gastroschisis associated with other anomalies? Not usually. Not usually. We can diagnose gastroschisis early because you'll see elevated maternal alpha-fetoprotein. But no, there's not usually an association with other disorders. Complications? What's the problem for these kids? Dehydration, sure, and malnutrition. And usually the long-term problems come because the bowel is exposed, it can get scarred down. And that requires bowel resection, can lead to short gut syndrome, and all of the problems that causes down the road. So this second picture, it's midline, got a sac. That's omphalocele. Associated with other disorders? You betcha. Which ones? Beckwith-Wiedemann is probably the one you'll get asked about. And they love to describe this baby. It's a big baby, it's got a big tongue, so you can kind of confuse it with hypothyroidism a little bit because of that. It's a big baby with a big tongue. Ear pits is the key. Remember when you flipped the little baby's ears over and you looked for pits in the newborn nursery? If you found one, you might be thinking Beckwith-Wiedemann syndrome, and omphalocele is associated with it also. Okay, so what about this third little cute baby? Small little defect in the midline. Yeah, so this is an umbilical hernia. Associated with other disorders? Yes, which one? Hypothyroidism. Very good. So that's our other baby with a big tongue. Big tongue plus umbilical hernia equals hypothyroidism. And what do we do to treat it? Or do we treat it? It should go away. And if it doesn't go away, by when are we worried? Yeah, 2 or 3. If it's still there and the kid's 2 or 3, consider surgery. But if you're given a case of a 1-year-old and the mom's freaking out because of an umbilical hernia, you tell her to cool her jets and it'll probably go away on its own. Okay, a vomiting baby. Got a 4-week-old infant, non-bilious vomiting, and a palpable olive. Okay, a vomiting baby. Got a 4-week-old infant, non-bilious vomiting, and a palpable olive. Okay, good. So we look forward to that question, right, on the exam, pyloric stenosis. The metabolic complication, very good. Hypochloremic, because you're vomiting up your HCl, metabolic alkalosis. Very good. How do we treat it? Got to cut it. Myotomy. You got to snip the stenotic part of the pyloric sphincter. So what about a 2-week-old infant bilious vomiting? The pregnancy was complicated by polyhydramnios. And has that abdominal x-ray shown. Yeah, it's some type of atresia. Duodenal here, we've got the double bubble, so that x-ray is duodenal atresia. But any intestinal atresia could conceivably cause polyhydramnios and bilious vomiting. Annular pancreas is another way that the intestines can be narrowed. So associations, good. Down syndrome's is the biggest, especially if we're talking about duodenal atresia. 1-week-old baby with bilious vomiting. Draws up his legs and has abdominal distension. Yes. So malrotation leading to volvulus. And remember these LADS bands? I had forgotten about that. When I was studying, those are the things during development that persist, and they're little pieces of peritoneum that kink the duodenum, and that's what causes the volvulus. So pathophysiology, if it's malrotation, We didn't have that 270-degree counterclockwise rotation that you, I'm sure, remember from embryology back in first year.
Mythology.